Hi, sorry I'm late. I got caught up in the lobby talking to people about Narcan. My name is Arlene Brown, and I'm the Recovery Support Navigator at the Rural Health Clinic. And I've been probably working in addictions for over 14 years now, working in Indian country for about 20 plus years. Huge passion for what we do here. I'm so grateful that we're having the Opioid Summit here. Exposure, the more education, the more we're going to reduce stigma, right? That light is bright, Earl. He warned me about that light. Yeah, I was pre-warned about this bright light up here. So we're going to talk about access to care, low barriers to care, and really, I think what that really means. Oh, there it goes again. Sorry. So what that means is we have a service, right? So whatever profession, whatever you're in, if you have clients, patients, people you work with in probation, whatever that looks like, you have a service and you have people that are needing that service, right? So we have things that people need. And if we make these barriers for people to get treatment, all we're doing is putting blockades in front of them to get accessing that help. So the whole goal of it is to be able to reduce and lower the barriers so people have access. And access can be things like what type of insurance do they have? I don't work with this population. There's been things in the community where people were turned away because they didn't have 30 days of sobriety. Who made that one up? I don't know. Those are all things that really hurt people from accessing that service, right? And so if you work in this profession, you are, in whatever that role looks like, you really have to have, you have an obligation to these services that you provide. So we can't just sit there and talk about all the warm and fuzzy things that are happening. We really have to look at our organizations and ourselves and say, what kind of barriers does this organization have? Who's not getting access to these types of services? And one of the reasons why I'm super passionate about working in addiction and why I get so serious about access to care is because it's life and death when it comes to addiction. People are on a life and death errand to save their lives. So if professionals are sitting here making barriers to care, like you have to prove to me how much you want sobriety, no you don't. Nobody ever has to prove to me how much they want to save their life, because that's what it comes down to. And so here's the other piece of barriers. If we know about the problem, opioid epidemic, substance use disorder, alcohol, methamphetamine, we know about the problem. We talk about the problem. We even have meetings about the problem. And we sit here and we have resources, the ability to address the problems, and we sit here and do nothing about the problem, we are at the very least the problem. And not only that are we just the problem, it's even worse because we're negligent, but even worse than that is we're the oppressor in the situation. Because what I've done is built up walls and barriers to service. I made you jump through hoops. I've made you prove how much you want to live. I've put all these roadblocks. I've given you referrals to other agencies and nothing was ever done. These are all just ways, even stigma. So when somebody calls up and wants help and I don't receive them, or somebody is not trained on how to receive somebody reaching out for help, that's a barrier. They don't come in. They feel there's no trust for the organization, the institution, or the people that are working in there. They feel ashamed, and we just heard a whole big thing about how much people feel ashamed, and how are they even going to reach out for help if they don't have trust for the organization or the people that have the services. They're not going to. It's super hard to be able to do that, right? So that's why I said we have to really examine what our barriers look like as a whole community, not just one organization, institution, or whatever, but as a whole community, to make sure that we're addressing this appropriately, and so that we're not sitting there making people prove how much they want to live. That shouldn't be the case, but it is, because we all have these barriers, and but the more access we create, more access points, and the lower these thresholds are to care, the better off everybody is going to be, right, in the town for community wellness and healing. I really appreciate what I've heard so far this morning, because I'm really big on the fact that it's just not one thing. So naloxone's not going to save us. One piece of harm reduction isn't going to save us. One organization isn't going to save us. It's really a whole community approach, and making sure that we're investing in the community to receive our populations. And there is a group of people that are not being received well into the community, that are coming from prison, jail, and they're coming out addicted. And how are we receiving them when they're coming out this way? So that's why I say I'm really passionate about being able to receive populations, especially if they feel like they're stigmatized against, or that they're discriminated. I believe I heard Dr. Waller talk one other time about stigma is discrimination, and discrimination kills. So if I have people that don't want to come in to get help because they feel like they're being stigmatized, they're not going to get the help. And what's going to happen? We have people who aren't sitting with us today because they've lost their lives to this. And we have friends and families who have lost this life. So that's what I really want to say about the importance of access to care, making sure that we are available, making sure that your journey to recovery is your success, not mine. I don't know what success looks like for somebody. I know what stabilization does for somebody. Dr. Willer talked about the motivation. I know what that looks like, but every individual is on their own journey for recovery, and so that's why, the less barriers we have, the better. People need the treatment, they need the services, but back to the fact that, we can't, if you have the resources to do something, do it. I was called to do something about the opioid crisis because I'm from here, I know my community, and I know about harm reduction working in this field, and so I was called to do something. I couldn't sit here and do nothing while my friends had loved ones dying. And so that's really that message, but I urge you guys to take a look at your organization, to say what resources you guys have that you can take action now and do something. Everyone has a role to play, whether they're a community member or not, or if they do work for an institution or organization, to become more educated. I have been really honored to be part of this really awesome team and working for the hospital. And out of this ED Bridge grant, and they're going to talk about more of what the hospital is doing and whatnot, and what Earl's going to speak about Tyree, but the partnerships that have been created here are setting the bar for how outreach should look in our community, and how organizations can come together and be of service and actually really go in there and build trust relationships with people. And I'm going to pass the mic because I know I can totally keep on talking. So.
Mine's working too. So I wanted to, the main purpose of this meeting was really trying to tell the community what we're doing and what we do have available, because we want you to spread what we're doing in partnership with Toyabe and Mammoth, and there's a lot of different things that are happening. If you didn't know, we have an addiction task force that was kind of mentioned. This is a community organization that has been going on for about 7 or 8 years, as a matter of fact. And it kind of started off with an envelope system that you could mail back drugs, or you could find drugs in the family's home and you could mail them so that your children and stuff couldn't take them. And they asked me to take that over in October, and I went a little crazy with it, but I want to invite community members. We have the police department, we have probation, we have mental health, we have county services, we have Mammoth that's coming down, we have Toyabe that's coming, and we're meeting and talking about what is the problem and what are we going to do as a group to try to facilitate that. And so one of the things that we did, we started looking at different grants and what was out there that would help support and fund and help financially do this. And we applied for an ED Bridge grant, and 82 hospitals applied, 31 of us got accepted. So you can see there's a lot of hospitals out there that really want the help. We got really lucky with a lot of support from people and the things that we were doing that recognized some of the things that we were starting to push forward, and we got accepted, which allowed us financial support to hire Arlene. We didn't didn't want a recovery, we didn't want a addiction navigator, we wanted a recovery support navigator. So a John Hopkins model, starting to change those words and change those titles to say we're here to support, we're here to help. So we hired Arlene in April. We allowed Dr. Goshgarian and the emergency room team to become ex-waivered so that they can prescribe the Suboxone. The theory behind the ED Bridge is that's a main access point for everybody in the community. If you're sick or if you need help, you could go there and the physicians there can prescribe buprenorphine, Suboxone, so that you can get treated, and then they call us. Once that initial treatment's done, then we can try to facilitate. Maybe we go back to Earl and you get back into your community. Maybe you come and see us for that kind of support. We'll continue that treatment for you as you come back into the rural health clinic. You don't have to be a patient of the rural health clinic. We would see you, we'd get you registered, we would get you, and you could still have a primary doctor somewhere else, but we would help support you with your Suboxone and your heroin, opioid use, alcohol. So it's more probably, the beauty of this whole thing is it's turning into a substance use program, probably more than just an MAT, but we do have an MAT program. Currently now, I have 26 patients that are on Suboxone. To me, that's 25 to 26 lives that are alive right now. I have, we're about 25 to 26 other drugs, methamphetamines, alcoholism, that kind of stuff that we're getting in. We're getting them coming to see us. We're getting them into therapy. We're going to get them into treatment. So, so the ED Bridge grant was just a super success. We are also applying for the Narcan grant. You saw the Narcan that's being distributed. We're also going to have Narcan. Police department's going to have Narcan. Toyota's going to have Narcan. We're going to have this place flooded with Narcan. Because I think the goal is we don't want any more people to die. I think I've lived in this community my whole life, and a lot of us still have our head in the sands that we think that it's not there. There are needles on the ground. There are people that are dying, and you don't see it really in the paper. We had 8 deaths that we know of last year, and it's interesting how they get labeled. They get labeled as a car accident. Happened to have heroin and fell asleep and ran into a tree, but their cause of death was a motor vehicle accident. So there's more out there than what you think. There's more out there than what you hear, and hopefully with the summit and with the collaboration and what we're doing, more people are going to come and ask for help. I mean, that's our main focus, is people to come and ask for help. Also growing up in this town too, I'm going to be curious how this is going to go. We are applying for a needle exchange program, and through CDPH and HIV program, but also to hopefully stop the spread of HIV and hepatitis C. And we do treat hepatitis C in the rural health clinic too. We have Dr. Tom Boo that's there, that we sit on a national board of hepatitis C and the appropriate treatments and what can be done. We'll get your medication authorized and approved for you. So it's another access to hepatitis C. But the main thing from the syringe exchange program is to try to reduce harm, to stop the spread of infection, and hopefully, and give them access to come in and get treatment. So if we're going to give syringes, there's going to be a little piece of paper on there that says, come and talk to Arlene if you want to stop. We don't want you to get HIV or hepatitis C, but if you want to stop, come by and say hi, and we'll see if we can help you. That's pretty much all I had. We also are going to apply for a hub and spoke. If you don't know what a hub and spoke is, the bigger cities have what's considered to be the hub, and basically what they are is, and we would be considered a spoke, and what it is if we needed assistance from an inpatient treatment or higher level, or maybe some financial support for somebody that can't afford their medications, that hub is the one that we go to and ask for assistance, and they pay for some of the meds, they help for some of the patients that we're having difficulty with. We're looking at telemedicine. There was mention about telemedicine. We're looking at telemedicine psychiatry. We're looking at increasing our behavioral health therapy. So we've hired a phenomenal social worker that's is providing some of the group therapy with Arlene, hoping to expand that as well. We have RN care coordinators that help facilitate that. So, and I try to make it really easy. It's a one-stop number. There's pamphlets that are out on the hospital out there, so you can give them to family, you can give them to friends. If someone wants to call in, all they got to do is say, I want help, and we'll call them back. Like Arlene said, we're not going to ignore those phone calls. It's a confidential line. It's you can leave information on there, and we will call you back, and we will do whatever we can to facilitate help. So that's what I have.
Next, I guess. So my name is Ann Gashgary, and I'm an ER doctor here. I unfortunately did not grow up in this area, but it's amazing, and I wish I did. I have been asked a lot of times why the emergency department has gotten involved with all of this, from both members of the community as well as my own ER colleagues. And I think the reason for that is kind of twofold. First off, these are patients that we're already treating in the emergency department. We treat them for everything from abscesses secondary to their injection drug use to near-death experiences from overdoses. So these are patients that we're already treating. And I think the second reason that the emergency department is involved so much in this is because we are a 24/7 access to care point. These patients, like Dr. Waller alluded to earlier, some of them don't have the dopamine necessary to get out of bed in the morning, so let alone to make an appointment with their primary care doctor in a couple of weeks and remember that and get there. But a lot of them have the ability to get to the emergency department even if it's calling 911. So our doors are always open to everybody for everything, and this is no exception.
That's another huge piece, though, is the barriers that our patients are facing just to even get in. So thank you for letting me interrupt. Sorry, Bonnie.
You really might hear that. First of all, I apologize for the glare off my bald head from those lights. No one told me I needed sunscreen or a hat. So this has been kind of an interesting little journey from a law enforcement perspective. This normally is not our role and is not very popular amongst my peers. It's viewed as more of a touchy-feely kind of thing. So we're still going down that journey, and as far as convincing my peers, we're working on it. Basically, I got into this by luck, I feel like. We were doing a presentation at the high school, and I was able to meet with Arlene, and we were doing this presentation, and it kind of evolved into me being involved with this task force. Where I've seen a great deal of success, I think, is from a law enforcement perspective, we have a lot of frontline interaction with people that are struggling. We are talking to people that are living on the streets or that are battling addiction and that are having an overdose. We are responding to the overdose. We're getting there before the ambulance does, and we know a lot of these people on a personal basis. So what we've been able to do is, if I'm coming out in contact with somebody, and right now it's just me, but I'm trying to spread that amongst my peers. When somebody is reaching out for help out in the field, instead of us going there and having them be afraid that all we're there for is write them a ticket, take them to jail, that sort of thing, is give them the hope of maybe getting some help for their addiction. So far I've been able to work with Arlene, and we've had some successes where we do have some people that I came in contact with and they reached out to help, and we were able to get them in the program. I came into work this morning after a 2-week vacation, so I look really tired. That's why. My vacation was swim meet, so I did not
You do.
But I came into the PD this morning, and one of the first things that I was confronted with was, hey, while you were gone, we had somebody come in that we arrested, and they said they hit rock bottom and they want help, and they were giving your name. So when they get out of custody, I'm hoping that that person is going to come contact me, and maybe we can get them linked up with Arlene. So I think it's been very successful, and I hope it continues. And I don't have a whole lot more than that. But the other part would be is I want the community to realize that, yeah, it's hard to trust somebody dressed like I am when you're maybe living that lifestyle, and if you're doing something that is illegal and does have a legal consequence. If you had asked me 14 years ago when I got into this, if I'd be sitting up here talking to you about helping you with your addiction, I would have said you're crazy. Because I want to kick your door, arrest you, and take you away for drug sales. That would have been my primary function. I am learning that there's two different ways to combat. We have different issues here. Somebody that's battling addiction is not necessarily an enforcement issue, as sales and that sort of thing might be. So trying to get it out to where you can trust law enforcement. We do come in contact with you. I am hoping that more people that are battling addiction can reach out to help. with law enforcement and not just have to step up and go to a counselor by themselves, because we are contacting people so often that are battling this. So that's the goal here, is to try to bridge that gap and make it where you can trust law enforcement, and that law enforcement can actually offer some help to you and not just a penalty.
I think your colleagues will come around when you have a few more overdose reversals with Narcan.
Yeah, we've had one successful one so far, so hopefully that continues. And I do know some of my colleagues that I'm working with have seen Arlene actually respond out to the field. I'll text her when I'm out in the field and I say, hey, I got somebody right now that's saying they're ready to get some help. And she's come out both times that I've used it, and it's been successful, so let's hope that continues.
No, it's awesome because, you know, I think of Sergeant Gladding as being the model for what we're trying to do and implement and get away from this punishment, because we know that doesn't work, to get away from punishment, to get away to how are we going to really address this issue. And this shows me, and the people that Sergeant Gladding has worked with, you know, it's because he's built trust in the streets with them. And then he's like telling them, oh, I got help, like someone's coming. And then like all of a sudden somebody comes and they're like, you weren't kidding, like somebody really is coming. And I think that first person did not believe that Sergeant Gladding had somebody coming down there, and the look on the person's face was pretty priceless when they actually showed up. So the trust is instant, and when patients are going into the ED, are they feeling like they're discriminated against, or do they feel welcomed and non-judged? And from what I can tell you, last month, every patient that came in, they all got follow-up care. If I wasn't actually in the patient room with them, they all got follow-up care, and they all accepted help to treatment being in the program. And signing on. So I want you guys to know that the success is huge. And some of those were the referrals from Sergeant Gladding, and the good work, because somebody said, you know, Dr. Goshgarian is amazing. And I was like, really? I said, tell me more about it. She sat there and listened to me. I've never had a doctor sit there and listen so much. And I thought, wow, that is huge. And so I know that the people, I trust this process, because I know when they're going in that they're being taken care of and they're not being discriminated against, and that stigma is not there. And so that's a huge goal. We want to continue working towards that, to make sure that they do have trust with law enforcement, that they do trust the ED, that they do trust us to accept and engage in treatment afterwards, and that they know that there's a program there that absolutely is going to help. There's another piece of this access to care, and I have to identify that there's a community member out there doing harm reduction on his own, helping drive people to treatment centers, because people in the community trust this person so much, but they're turning to him. And the reason why I have to bring this up is because I said we have to take a really hard look at what our mental health system looks like. We have to take a really hard look at that and address it, because there has been a gap created, and so now a community member is filling this gap and trying to get people into treatment centers. That's huge, right? They're asking for Narcan trainings in the home and whatnot, because people really trust this person because he's out there in the streets, with them. To me, when I look at that and I think, why, if everybody is doing the best job that they can and we're not having the barriers to access to care, then a community member with his own resources and own money wouldn't be sought after to get somebody help into treatment, right? That's where I want to address that there's a huge need there, and so it's important that we have the ability to just look at our own organizations to be able to flesh those out and say, okay, there's a need, let's address it. And that's the whole point, to being able to have access to care, right, and lower these barriers. So I just had thought about that, and I wanted to make sure I pointed that out, because everybody is working really hard to move forward and get new programs going and everything. But realistically, we have to be focused on not just the good, but also the bad, because otherwise we'll miss it, and we'll just keep doing that. Because the other thing, access to care, when we put more barriers, it's not just the person out there who needs the services, we isolate ourselves with these barriers, and we build this wall between us and them. And then the professionals don't see the reality of who's sitting on the other side because they've lost touch. Why? Because they sit behind that wall that the organization, institution, the system itself has created. And so now you have these two people that can't even talk, and that's not what MAT is about. It's about doing the exact opposite. And that's what I really love about being able to work in do this program, is the ability to address those issues and make a program that has people in the trenches knowing the real deal and not contributing to withholding services.
I'll have to follow that up. Before I get started on my discussion, on behalf of Toyabe, we would just really want to recognize Dr. Flanagan, and I know he just stepped out, but we just want to recognize his leadership and his ability to reach out and help bridge these gaps between our service agencies and our communities, because that's what we're looking at as our overall goal, is to find out where we're lacking in certain areas and come together to fill those gaps and help better serve our community, and also be there as a true representative of what our community can be. Like Dan, Arlene, and Ron, I grew up here, was born and raised, and went through the school systems, and I truly feel that I want to see a better community for my children coming up, because one of my biggest fears is that, they can fall into addiction and have that suffering. And as a child, I grew up in a dysfunctional family that had addiction all around it. And if it wasn't for the programs like Toyabe, like NIH, law enforcement, these mentors to be there for our youth and for myself as a kid, I probably would be on the other side of the ball field. So my community is dear to my heart, and I want to do the best I can to help make the change. And sometimes I sit back and I wonder, wow, how did I get where I am now? How am I working in this field? And I truly feel that this path chose me. I started out at Toyabe in prevention, working with the youth. I had the ability to move up the ladder, we say, to step up to the big leagues and get involved in SCD and work towards getting my KDAC, and that's where I'm at now. And also have a lot of inspiration coming from this person to the left of me, and also some of my colleagues at Toyabe. And so I'm just happy to be where I'm at, and truly honored, and I truly want to help better our community, help them heal. And I'm always learning, and I'll continue to keep learning. And I just want to recognize some of the programs that we're doing at Toyabe, as far as the opioid response and SCD capacity. We wrote some of these down because I have a tendency to forget what's going on, because everything is happening so fast, because we're trying to adapt to this epidemic. And so currently Toyabe has 7 X-Wave providers, 2 MDs, 1 PA, 3 FNPs, and 1 telepsychiatrist. Suboxone is now being carried in Toyabe's formulary at pharmacy. So the patients that do get prescribed Suboxone, they'll be able to receive their medication in-house. They won't have to go out to seek their medication. We're currently in process of hiring an MAT program coordinator. We're keeping our fingers crossed. Hopefully this person will accept the position.
They accepted the offer, so.
Awesome, they accepted the offer that should be the program, because that will be the person that will be leading the charge as far as developing the MAT program policies and procedures and getting that off the ground. Our SUD program's growing. Currently I'm a substance abuse counselor 1 trainee. I have my registration number, continued my schooling and my supervision hours so I can test for my KDAC. We have Tony Huff over here, who's currently taking the same path as me. She's working on her schooling and she's a substance abuse counselor 1 trainee. We're currently hiring a new LCSW who's also a licensed drug and alcohol counselor, so he's a LADAC, to help grow our substance use treatment service, and that he'll be starting in August. So these are all efforts that we're just trying to get back up to speed with what's going on and get a handle on this STD and opioid epidemic. The department is growing. We're building capacity. Family Services has added 8 staff since January 2019. 3 more staff are starting next month. We got 2 prevention workers that I'm so grateful for. It really frees me up. I'm not spread so thin in trying to do prevention and substance abuse. I can really start to focus on my substance abuse efforts and getting my supervision hours and really buckle down on these grants that we have. Our Tribal Opioid Response Coalition meetings are attended by multiple partners. OBCDC, I'd just like to give a shout out to the OBCDC. They provided the lunch today, so if we can give them a round of applause. Owens Valley Bishop Tribe, or OVBT, excuse me, that's the Owens Valley Board of Trustees. They have a seat at the table at the Tribal Opioid Response Coalition meetings, as well as the Bishop Paiute Tribe, Bishop Paiute Social Services, Elders Program, Inyo County Probation, and NIH. Narcan trainings are continuing. We just did one on Friday at the MIPA conference held at the Bishop Elders Program. We have a Narcan training that we're working out the details for OBCDC, TANF, and also Benton. And I just mentioned the Elders training that we did on Friday. Providing Narcan to patients and family members that report concerns about opioid use. So I truly have that open door policy at Toyabe. Arlene was talking about low barriers of access and low barriers of care. I truly feel that having that open door policy and extending that warm welcome to people that are suffering and are really isolating themselves and have that stigma and that shame that surrounds them. If you ever need to talk, come in, and if I don't have the right answers or resources for you, I can get you linked up, and that's what we're trying to do with this Opioid Response Coalition, to build that team so we can provide that linkage of care. So this right here is another big thing that we're putting all our efforts into. I'd like to thank Coco, Michelle, all the Toyabe staff, and all the agencies and affiliates that helped put this together, the Opioid Summit. And we really want to thank all the community members that came out today. And then our medication assisted treatment program is, like we just said, we just announced the hiring of the MAT program coordinator, and we'll be able to develop policies, procedures, staffing needs, workflow, and a budget. Toyabe is going to apply for the RCORP, or they already applied for the RCORP grant in collaboration with NIH and Mammoth Hospital. We signed a contract with Telewell Behavioral Health to provide telehealth and MAT to our community through that program. We just did a white bison training, which was awesome. Just want to thank everyone who attended that. And it's a cultural-based curriculum that focuses on the 12 steps and bridging that into a circle, that 12-step program. We did a craft training, which is another evidence-based practice for working with families struggling with substance abuse. So it's a really good program that focuses on intervention and how to talk to a person without yelling and screaming at them and telling them they're no good and pointing the finger at them and it's all their fault. It gives you a really good approach on how to talk to a loved one who's struggling with SUD, and how to look at them and also look at yourself and see how your words really do mean something to that person and can affect them in a way of negativity and actually turn someone away from recovery. So that craft approach is great. And then we're also exploring contracting services for community outreach and harm reduction education, which I'm trying to push that forward because, like Arlene said, we have community members out there that are taking people to rehab, doing all this hard work out in the community, and I think they really need to get recognized and actually get compensated for the work they do. So we're looking at doing some contract services with recovery specialists within our community, people with lived experience that can get out, can reach that population and provide that linkage to care, and really help push on that fact that we have some good programs going on here, and if they're willing, we can help them out the best we can. So that's all I have.
I know we're going to run out of time. I did want to emphasize to the community that, like Sergeant Gladden said, that we did do a presentation at the high school. And I think one of the biggest things that I took home from that is, it was 2 presentations, one in the morning and one in the evening time. And we had 4 students that came up to us after that presentation that asked for help. And I think even if we got 1 person that asked for help, it would have been a great thing. We had 4 young children that came in and asked for help. I think that we got to recognize that it's there. We do have a school-based clinic that's there. I'd like to partner with Earl and Toyabe so that there can be Toyabe present in that clinic as well, because they trust him and then they can come to him and they can, have a point of contact to talk to. So if we have the avenue for that to happen, would love that partnership as well. So kind of got a couple of minutes for questions. If anybody's got some questions out there.
Great question. Thank you, Dr. Brown. So Inyo County has a 18-month planning grant, and actually Dr. Waller is going to be talking about that this afternoon in kind of MAT in the jails and prisons, and like a criminal justice. And so we've been collaborating and kind of in on some of the early meetings with the jail and with the county on what that's going to look like. Currently, though, right now we do have a good partnership with the nurse down there, and so if patients are going in, that we're able to catch that, but they're going to be doing an 18-month planning grant, and after that they'll be able to get funding to implement it. So right now we have a partnership with the nurse, and so we do receive patients. We had a patient get released on a Saturday, and all I could think about, and I don't work Saturdays, and I don't like to work Saturdays. But we had a patient come out, and he had an appointment on a Saturday, and all I could think about was I need to be there to meet that patient at the clinic, because I want to make sure that they know we got their back, and that we get it right from the get-go, because it's really important to me when I said we want to receive our inmate populations, anyone who's coming in back from treatment, we want to make sure they're received, not just, oh yeah, go, there's a 12-step meeting, go here, go there, and that's what happens, right? So it doesn't work. And so I wanted to make sure that I already built that relationship with that person and let them know, hey, yeah, you're here, we're here, we're partnering on this together. And so we do already have a loose partnership, and that's only going to be strengthened through different MOUs and whatnot, but it's a good thing. And so I had a person, somebody told me, well, I might be going to jail. And I said, well, call me after court, and I hope, it doesn't go that way, but call me after court. And just so you know, you can let Colleen know that you're in the MAT program and you'd like to continue MAT in the jail and stuff. And they didn't have to go to jail, but I'm able to have that conversation with patients and say, yeah, if they have MAT in the gym, they're like, what? I'm like, yeah, they'll help you out. Like you can, you can do it. We don't want to interrupt your treatment because we know from a medical stance this is a treatment. We want to continue and not interrupt for them, right?
Was there another, I thought I saw another hand up there. Was there another question?
Earlier, I heard someone say that pretty much new laws offer protection. Most people might miss the they said that, but not if you were on probation or something along those lines. And I would agree, is that true? That's how it seemed to me that the most likely person to be present in the presence of someone who overdosed would be another person using drugs. And let's say that that person had administered that drug, just happened to have some other with it, but didn't have the training you're supposed to have with the law. Would you arrest that person, sir?
What I know, as far as the rules with probation, I honestly can't answer that question, but I know a whole bunch of people in that general area that can. No, you know, from a law enforcement perspective, we're gonna go into every situation, and they're all gonna be different. And hopefully, and I can't speak for all of my peers, brothers and sisters out there, they may have a different take on it than I do, but we're able to enforce using spirit of the law. So I can go into a situation and I can make a decision. Yeah, maybe there's some possession issues, right? Maybe we have possession of heroin or we have whatever it may be. I can make the choice and look at that and say, is it going to be better for the community? Is it going to be better for the person if I arrest this person? Or is it going to be better if I can maybe get them lined into a treatment option? If this is somebody that wants that, right? Every situation is going to be different. But just to answer the question at face value, am I going to arrest somebody because they administered Narcan to somebody overdosing? Not a chance.
Now,
Right.
all the officers at UD have administered,
Yes.
and you know whether or not the sheriff or
I don't know if they do or not. I couldn't answer that. But yes, like all of our patrol units, we have Narcan. Each officer is assigned his or her own Narcan, and they're taking care of it, taking it in and out on patrol so that it's not getting too hot, not getting too cold. We also have it within the station because we do have a facility, a temporary holding facility. So.
That's a good question. Citizens are protected under the Good Samaritan law to administer Narcan. And I know you kind of elaborated on extra questions, like if someone's on parole and they're around and paraphernalia and what that looks like. So, but normally, generally, the Good Samaritan law will protect people that administer Narcan. And if something happens or it wasn't an actual opioid overdose, that person is protected if they do the administration.